It is a inflammation of medullary cleft. Duration is important, more than 2 weeks. That results discharge from ear. What are the types of chronic otitis media? Active, inactive and healed. Active means there is discharge. Inactive means there is stoppage of discharge due to medical treatment. Healed means there is no infection inside the medullary cleft and there is healing of the perforation. Now classification. Healed chronic otitis media, healed means there is automatic closure of perforation of the TM. Inactive mucosal, that is perforation, that is called inactive mucosal. Inactive squamosal, that is retraction pocket pathology. Active mucosal, active squamosal. Now cholesteatoma. What is cholesteatoma? Definition. It is a three-dimensional epidermal covered by connective tissue matrix. It is tumor-like thing. So it is a three-dimensional SOL type thing lined by epidermal element and surrounded by connective tissue matrix, forming a sac composed of stratified squamous epithelium lining and desquamated keratin inside. This is attic cholesteatoma with a small central perforation conforming the medullary cleft. It is always lying in the medullary cleft, that is attic, mastoid or tympanic cavity. The characteristics of this cholesteatoma is there is capacity of progressive and independent growth involving the underlying bone and replacement of the medullary mucosa. There is a propensity of destroying the surrounding structure, bone, ossicles, and there is replacement of the medullary normal mucosa. Now to recapitulate the medullary cavity, there are three components: epitympanum. Epitympanum means this above this line, this is epitympanum, where handle of malleus, head of the malleus and body of the incus lies, and this part is called mesotympanum and this is hypotympanum. Now ventilation of the epitympanum. This is very important because attic cholesteatoma or attic retraction pocket arises due to defective ventilation of epitympanum, because it is ventilated through the mesotympanum by isthmus anticus and isthmus posticus. I already teach in your anatomy class. Now, what are the pouches and spaces related with tympanic membrane? This is very important to understand the cholesteatoma, and it is pathogenesis and progression of the cholesteatoma sac. First thing is Pusack space. Pusack space, superior inguinal space, posterior pouch of von Trott's and anterior pouch of von Trott's. Now Pusack space. What is Pusack space? It is small recess in the medullary. This is Pusack space. This space, bounded laterally by pars flaccida of the tympanic membrane. This is pars flaccida. Superiorly by sputum. This is bony sputum. There is bony attic, or it is called sputum. And lateral malleolar ligament. This is lateral malleolar ligament and bounded medially by neck of the malleus. This is neck of the malleus. Now posterior and anterior pouch of von Trotz. This is the pouch lies between tympanic membrane and posterior malleolar fold, and the inferior edge of which contains the cauda tympani nerve. This is cauda tympani nerve, and this just below this cauda tympani nerve, this is the anterior pouch of von Trotz. The pouch possesses superior medial and lateral wall, and it opens inferiorly towards the posterior tympanum. This anterior shallow pouch lies between tympanic membrane and anterior malleolar fold. This is anterior malleolar fold. Now, how disease is spread? Pusack space, through Pusack space, superior inguinal space, posterior pouch of von Trotz, aditas, posterior mesotympanic cholesteatoma involving the facial recess and tympani and extension into the mastoid cavity via posterior tympanic sinus and inferior inguinal space. Now, classification of cholesteatoma. Criteria, etiology and pathophysiology. Classification congenital. According to etiology and pathophysiology, there are 4 types: congenital, acquired, primary and secondary. Pathophysiology, location wise and ossicular defect wise and presence of complication wise, there are 5 types: congenital, acquired, primary, secondary and tertiary. Extension, according to extension of the disease, TMC classification, staging, ossicle complication, classification system. Location of origin of the tympanic membrane, attic cholesteatoma arising from the attic, pars tensor cholesteatoma, this is through the marginal perforation, pars tensor 2, it is central, through central perforation, sometimes cholesteatoma may occur. Direction and extension of the disease, attic, pars tensor, tensor retraction cholesteatoma, sinus cholesteatoma. Origin and location of the disease, pars tensor, marginal, central and congenital. Extent of involvement, pars tensor, attic, combined of the attic and pars tensor. Inflammation status, with infection, without infection, the dry cholesteatoma. No infection is dry cholesteatoma. What are the hallmarks of chromosomal variety of COM? Formation of cholesteatoma, formation of retraction pocket, squamous epithelial ingrowth. These are the 3 main criteria for diagnosis of cholesteatoma. Now, pathophysiology of primary acquired cholesteatoma. What is primary acquired cholesteatoma? They arises from congenital embryonic cell rest, Cawthon's theory, derived from immigration of squamous epithelium from deep portion of the external auditory canal into the middle ear cleft, Tumarkin theory. Persistent negative pressure causes immigration of pars flaccida, that is attic part, creating a retraction pocket in the attic which gets filled with epithelial debris, creating a nidus of infection, Toss theory. He classified this retraction pocket into 4 grades. Metaplastia theory, epithelium in the attic area undergo changes in response to subclinical infection. Now, danger of cholesteatoma. What are the danger of cholesteatoma? First, along the perivascular space of varicose vein, progressive thrombophlebitis of small vessels, round window, oval window. Through the round window, oval window, infection in the middle ear may spread into the inner ear. Congenital aberrant arachnoid granulation or giving to meningoencephalitis, acquired temporal bone involving the otic capsule, surgically created defect. This is the iatrogenic defect. Through the defect can go inside the cranium. Most common pathology in which this is extended by the middle ear cleft through the erosion of the surrounding structure. Why does cholesteatoma have bone eroding property? Cholesteatoma is main characteristic is destroy the surrounding bone. Old theory is pressure theory due to accumulation of keratin flakes inside the sac of the cholesteatoma. They gradually increase in size of the sac, creating the pressure and thereby destroying the surrounding bone. That was the old theory. Current theory is enzyme like collagenase, acid phosphatase, protease are associated with cholesteatoma. Generated by osteoclast. Osteoclastic cells are generate inflammatory cell associated with it. TNL alpha, lysosomal hydrolase, cephalin B and IL-8 and calpain 1 and 2. These are the enzymatic in digestion of the surrounding bone. What is congenital cholesteatoma? It is an epidermal tumor originating from epidermal rest located in the temporal bone adjacent to the meningeal space. Area appears as whitish globular mass lying next to the intact tympanic. This is very important. There is no perforation in the tympanic membrane. Tympanic membrane is intact, and below the tympanic membrane you can see a white sac. What is the cholesteatoma sac? What are the Leverson criteria for congenital cholesteatoma? Mass medial to the tympanic membrane, normal tympanic membrane. There is no perforation in the tympanic membrane. No history of ear discharge. This is very important. There is no history of discharge. Local atresia or intramembranous and part cases excluded. Primary acquired cholesteatoma, cause is unknown. No previous history, lesion just arises from the attic region. So, primary acquired cholesteatoma arises from the attic region. Secondary acquired cholesteatoma always follow active middle ear infection which destroy the tympanic membrane along the annulus. There is a marginal perforation in the tympanic membrane. This is called secondary acquired cholesteatoma. This predisposes the epithelial migration of the canal to the attic region. So, there is migration of epithelium from the deep part of the canal inside the middle ear cleft, thereby causing cholesteatoma. Clinical feature of cholesteatoma: history of painless otorrhea and hearing loss. So, it is painless otorrhea with hearing loss is the chief complaint. On examination, drainage granulation tissue in the ear canal. There is granulation tissue. Granular tissue is a clinical entity for unsafe type of CSM like cholesteatoma. Evaluation. How will you evaluate? From history, scanty discharge with unexplained hearing loss, and there is unexplained hearing loss due to bone destruction and ossicular chain destruction. Head and neck examination, otology examination, uniform examination, pure audiometry, tympanometry, there is flat tympanogram, CT scan of temporal bone sometimes required. Management: oral toileting, antibiotic, grommet insertion to manage the early retraction pocket. Early retraction pocket, that is called retraction cholesteatoma, that can be prevented by grommet insertion in case of early stages, and canal down mastoidectomy, definitive surgery, that is canal wall down, canal wall up, intact canal wall mastoidectomy. That is the surgical management of cholesteatoma. Now, chronic otitis media. It is a medullary cleft inflammation more than 2 weeks, result in discharge from the ER. What are the types of chronic otitis media? Active, inactive, and healed. Active means there is discharge. Inactive means there is recent history of ER discharge. Healed means there is classification of COM. Healed, already told you. Inactive, mucosal. Inactive, coamosal. Active, mucosal. Active, coamosal. Mucosal and coamosal difference is, coamosal is unsafe type. Active means there is discharge. Inactive means there is stoppage of discharge for the time being. Mucosal variety. By definition, long-standing infection of the mucoperiosteal lining of medullary cleft, partly or as a whole. There is history of recurrent ER discharge. Non-intact tympanic membrane. There is always perforation in the tympanic membrane. Is tympanic membrane perforation. Why mucosal? Because it involves the part lined by columnar epithelium. This is the extremity opening, and this lining is up to this is protympanum, and this red part is lined by columnar epithelium. So, eustachian tube, protympanum and mesotympanum is the part lined by columnar epithelium, and here infection is located within this area. It is also called tubotympanic type or safe variety or benign type. Tubotympanic type means it is tube, eustachian tube and tympanum, mesotympanum and protympanum. Why it is safe? There is least chance of any complication. Etiology. It is sequelae of acute otitis media. Already you learned the acute otitis media. Acute otitis media with perforation, if not healed, that can lead to chronic otitis media, and sequelae of secretory otitis media. What happens in histologically? There is degeneration of fibrous layer of the mucous membrane. Necrotizing otitis media. What is that? It is caused by a very virulent type of bacteria, streptococcal otitis media. In case of measles and scarlet fever, there is destruction of the whole of the tympanic membrane, even the destruction of the ossicular chain also. Abnormal eustachian tube, more in children, you already learned. In case of children, their eustachian tube is more horizontal and short, and there is presence of adenoid, and so there is chance of recurrent infection of the medullary through the eustachian tube in children. Poor mastoid pneumatization. In case of sclerotic mastoid, there is chance of otitis media is high. Traumatic iatrogenic allergy to ingested milk and eggs. This is due to allergic cause. Pathological changes in mucosal type of chronic otitis media. There is always perforation of pars tensa. Medullary mucosa is chronic inflammatory infiltrate, increased number of goblet cell and ciliated cell. So, there is inflammation in chronic mononuclear cell in chronic inflammation. Cholesterol granuloma, foreign body granuloma, it is a foreign body granuloma, and nidus is cholesterol crystal, frequently found in chronic inflammation. There may be polyp, it is pale polyp. In case of safe type of CSM, polyp is pale in color. Ossicular chain necrosis, it is long process of incus necrosed first, then step is superstructure, then handleomalias. So along the ossicle, long process of incus is vulnerable for avascular necrosis much high. There is tympanosclerosis, that is sclerosis of the meningeal structure, giving rise to deafness, fibrosis and adhesions. Perforation of pars tensa, persistent infection in the meningeal, persistent extensive dysfunction, very large perforation and epithelialization of the margin. Perforation margin become epithelialized. Thereby there is no chance of automatic closure of the perforation. Organism, aerobic and anaerobic. It is mainly of gram-negative bacilli, Pseudomonas, E. coli, Proteus and Staph aureus, anaerobic bacteroids and anaerobic Streptococcus. What are the stages of COM, co-muscle variety? Active. Active means there is otorrhea, there is perforation and last year discharge, it is present. Quiescent means less than 6 months, there is no discharge, perforation is present. Inactive means more than 6 months, perforation is present, no otorrhea. Healed means no otorrhea, no perforation. Symptoms, ear discharge, character is very important. Color, colorless or yellowish, it is only there is least infection, then discharge will be colorless. Green discharge, it is due to Pseudomonas infection. Creamy white discharge due to Staphylococcal infection. So you can assess from the color of the discharge which bacteria is marked mastoiditis. In case of marked mastoiditis, amount is very profuse. Intermittent aggressive factor is relieving factor. Foul smell is due to anaerobic bacteria, Proteus or E. coli. Smell is very foul. Blood stain in case of granulation tissue and granulation polyp. Hearing loss, it is always a conductive type of hearing loss due to defect of middle ear conduction system. Due to perforation itself, size, location, perforation, size, location is important for conductive loss. Ossicular discontinuity due to ossicular chain destruction, edema and granulation tissue and tympanosclerosis. All these cause degree of hearing loss. How much hearing loss you can encounter. This can cause also sensorineural loss. How sensorineural loss happens in case of COM? This is due to bacterial toxin, toxin labyrinthitis, ototoxic eardrops. Due to ototoxic eardrops, the drop passes through the perforation and through the round window and goes to the labyrinth, causing neural deafness. Mainly high frequency hearing loss is there due to close to the basal turn of the cochlea, because basal turn of the cochlea is responsible for high frequency hearing. Paradoxical hearing, what is paradoxical hearing? It improves hearing during discharge. When there is discharge, the patient hear better than when ear is dry. Due to phase difference of sound conduction system. Symptoms, otalgia, tinnitus and vertigo. These are the main symptoms of otitis media comas variety. Now clinical examination. External auditory canal. How to examine the canal? You lift the pinna upwards, backwards and laterally and examine the canal. And you notice for discharge and excoriation of the skin. As it is a chronic discharge, there is chance of chronic eczematous condition of the external auditory canal. So, you examine the first external auditory canal. Then, tympanic membrane by ear speculum. You examine the tympanic membrane with ear speculum or otoscope. What you will see? Perforation. So, perforation may be single, may be multiple. If there is discharge, whether it is pulsatile discharge, and force shortening of the handle of malleus. Handle of malleus become shorter, look shorter due to rotation, posterior rotation of the handle of malleus. Handle of medullary mucosa, it is pale, edematous polyp. This is polyp. This is polyp. This is perforation. Ossicular chain. Examination under a microscope. The accurate documentation. Why you examine? Because your clinical finding will be documented by photography also, on print also. And if there is any discharge, you can suck it out. And otoendoscopy, photography documentation, discharge. Now audiometry, pure tone audiometry, speech audiometry. Pure tone audiometry, we can assess type of deafness and degree of deafness and documentation. This is the audiogram. Procedure is called audiometry. And the machine used to assess is called audiometer. So, meter, metry and gram, you have to differentiate between the three. This is audiogram. Red color is bone conduction threshold and blue color is air conduction threshold. There is a gap in between the two lines. If it is more than 10, there is conductive type of element is there. So, it is more than 10. One small gap is 10. So, here 1, 2, 3, 4, 5. So, here 50 decibel loss in this frequency line. Here 250 hertz, this 250 hertz. So, 1, 2, 3. So, 30 decibel loss. So, there is a conductive hearing loss in case of central type of perforation. Now, X-ray mastoid, lateral oblique view, and it should be bilateral X-ray. You should done X-ray on the both side. This is both side X-ray. This is extraordinary canal. This is sinus plate, dural plate, sinodural angle. This is sinodural angle. This is a sclerotic type of mastoid. No ear cell is there. Here, this is sclerotic type, this is pneumatic type. HRCT scan of temporal bone sometimes required, not always. Medical treatment. Medical treatment, limitation, you cannot do operation in case of child up to 10 years and very senior person not fit for surgery more than 70 or 80 years and immunocompromised patient. Preventive measures, avoid deep water bathing, use earplug to prevent the entry of water inside the middle ear, use good quality of bud to oral toileting, avoid use of mastic, septimin, etc. Purpose of the treatment, eliminate infection and control discharge. First aim of management is you have to control the active stage to make the active stage into inactive or quiescent, first quiescent, then inactive, then make the ear suitable for surgery. So, removal of the discharge, repeated microscopical oral toilet, this is method of oral toileting, these three method of oral toileting. And topical medication, this is antibacterial agent, antifungal agent and steroid. Steroid is used to reduce the middle ear mucosal edema and better entry of the antibiotic and antifungal. Antiseptic to create acidic environment. In acidic pH, this antibiotic and antifungal works better. Systematic antibiotic, these are three antibiotics commonly used: amoxicillin, cephalosporin and quinolone group of drugs. Antihistaminic, these are the three antihistaminic used. Non-response of this medical management. After the medical management, ear does not become dry. So, we have to investigate why ear is not dry by conventional medical management. So, what are the possibility for non-drying of the ear discharge? Poor drainage due to pinhole perforation, osteitis with granulation tissue. This osteitis and granulation tissue cannot be managed by medically. It is always required surgical management. And virulent and resistant type of organism. The organism become virulent and resistant to multiple bacteria, antibacterial agent. And persistent source of infection from adenoid, tonsil and mastoid reservoir. That is the marked mastoiditis. They are maybe reservoir of the inside the temporal bone, and adenoid in case of child, and in case of tonsillitis, recurrent tonsillitis, or adenoiditis, recurrent rhinitis, giving rise to recurrent ascending infection into the middle ear, giving rise to recurrent infection of the middle ear. And biofilm. Biofilm is due to injudicial antibiotic use. Now, surgical management. So, it is the focal source of infection giving rise to recurrent middle ear infection. First is adenoid tonsillectomy in case of child. From the adenoid and tonsil, infection goes up. Correction of the DNS, face for AC polyp or ethmoidal polyp, and correction of the cleft palate. In case of cleft palate, there is eustachian tube dysfunction. The definitive surgery, main aim is to correction of the tympanic membrane defect and correction of the sound conduction system by tympanoplasty and ossiculoplasty. This is 6 type of tympanoplasty. This is type 1. This blue area is the extraordinary canal. This is the handle of malleus. This is incus, this is stapes. The stapes is attached to the scala vestibuli. This direction of arrow, it is scala vestibuli. There is perilymph, and this is scala tympani, and this is oval window close by secondary tympanic membrane. So, in case of type 1 tympanoplasty, there is only closure of the tympanic membrane defect. Ossicular chains are intact. That is called type 1 tympanoplasty. Ossicular chain intact, only defect is tympanic membrane. We close the tympanic membrane by temporal fossa or tragal pericardium. Type 2, here malleus is destroyed. Okay. So, graft is placed on the incus. Incus over the incus, the tympanic membrane is graft is placed. This is type 2. Type 3, it is called meningostapedopexy. It is the stapedia's head. You can see, and graft is placed over the head of the stapes. This is called meningostapedopexy. Type 4. So it is graft is placed over the fruit plate of the stapes. This is fenestration operation. There is third window is created over the lateral semicircular canal. This is lateral semicircular canal. There is third window is created. This is cava minor. There is a making a small air pocket over the station tube and covering the round window, giving rise to a phase difference. This is drop and prop. This is the ossiculoplasty. This is the titanium prosthesis placed underneath a cartilage. Over that graft is placed and it is anchored with the stapes. It is the total replacement prosthesis underneath the cartilage and foot plate of the stapes, where superstructure is lost. So there is different type of ossiculoplasty by torque or PORP, and there is 6 type of tympanoplasty.